هذا بيقلبنا. بسم الله الرحمن الرحيم. أسأل الله صباحكم بالخير جميعا. بس عشان تنوروا طول اليوم. So thanks chairs, thanks a lot for organizing committee to give me the chance to talk about this one of the big tasks. I hope it will be of benefit, of informative for these few minutes. So the SGLT2 inhibitors يمكن بعضهم ينطقوها SGLT2 inhibitors. So what's the benefit to the cardiovascular system? والسؤال هو دائما اللي بيخطر على البال when the salts and sugars works together. So this is the two different things works together in this topic. I have nothing to disclose regarding to this talk. It's a matter of sharing you, meeting you, and to do this talk with your nice conference. Let me guess at the beginning to give you a questions to keep it in your mind. The questions: which of these statement is correct about SGLT2 inhibitors? Is it reduce the systolic blood pressures by 3 to 5 millimeter mercury? Is it reduce the intraglomerular pressures and albuminuria? Is it a cardiac and renal drugs rather than diabetes drugs? Is it could give it in sick days of patients? All the answer of all of these things. So this is just keep it in mind. We'll go through these things during this talk. And my talk home message is the SGLT2 inhibitors, a new era of heart failures medications. And it is a cardiorenal protective drugs. So it is a cardiac and renal drugs rather than a diabetic drugs. So the question again comes in mind: why could patients with heart failure with or without diabetes benefit from SGLT2 inhibitors? So what's the mechanism beyond these things? So the mechanism is simple. So it is a matter of glucosuria plus natriuretic effect. It's occurred because of inhibitions of SGLT2 inhibitors in the proximal tubules, leading to secretions of glucose and sodium. So all of these, it will give you benefits. The benefit of cardiovascular system, what you want after these functions is these things. Plasma glucose, it will decrease. The body weight, it will decrease. The blood pressures, again, it will decrease. And the plasma uric acid, it will decrease. The glomerular filtrations, it will be hyperfiltrations. So all of these things lead to things beyond what's our rationale of these drugs, how it could be used. So if we just go, what's the history of these drugs and how it came to our minds? The first item start to these drugs, it was in 2015. And the first drugs was discovered, it was Gliflozine. And the first study was going in these drugs, it's Gliflozine outcome trial. Then after that, it came to the Gliflozine, that's Canvas program trials. It was in 2070s. Then in 2090s, the declared trial, dapagliflozin. And then after that, canagliflozin by the CRANDIS or cardiorenal trials. And the last one, it was ertogliflozins in Vertis cardiovascular trials. So this is the story is like that. And the story is coming from 2015 up to now it's going. So it's going like that by different stories and by different studies applied. So how they think that it will affect the cardiovascular system and the other system as a protection for this drug. In the beginning of era of these drugs, they thought that it is just only affect diabetes with cardiovascular system and risk factors beyond this. And then it start to think, is there any other benefits? They work even with diabetes or not? So they said yes. So they start to study it with established cardiovascular system disease. And then it gives a benefit effect. Then they use it with or without diabetes and the endpoints of benefits. So what's the rationale? Why they are using this drug? The rationale for exploring SGLT2 inhibitors is the following. Patient with heart failure has similar pathophysiological features as patient with diabetes. So the other things, glucosuria and natriuresis, it will happen with SGLT2 inhibitors with or without diabetes in patients. And so the cardiovascular system benefits, it will be observed with these drugs, with the patients have diabetes or not diabetes. That's why the mechanistic rationale to investigate the cardiovascular system outcomes of these drugs is become beyond that the patients have type 2 diabetes. So this is just an example that the heart failures is reduced in that patients with or without diabetes, either any different type of heart failures, either have BEF, have MREF, or have REF type. So this is an example. If even the patients with renal disease, as you know that the limit of such drugs is the glomerular filtration rate is 20. So if the patient they get benefits, yes, this is EMBA-REG outcome trial. They said it will get benefit either from the heart failure or cardiovascular death. So the benefit of this, if you see, they favor empagliflozin in such patients. So again, what's the mechanism or what are the thinkings of the cardiorenal protections effect? So this is simply, if we just think of the renal arterioles, when they are the same here, they just make the gliflozine increase, the decrease in constrictions of afferents rather than dilatations of afferents. Then if we give SGLT2 inhibitors, cause renal arteriole afferents, it will be constrictions. And it leads to many things it's having in those patients, which I guess you say it like that. It will improve the ventricular loading contractions, diuresis, natriuresis, after load reductions, and improve the myocardial energetic effect and metabolism. Besides that, it will have direct effect in the myocardium and even in the metabolic factors, which you will see later on. So this is in diabetic or not diabetic patients. You will see just the end result for both of these type of patients, it will be the same. Either it is diabetes or non-diabetes. Again, you will see also the glucose excretions. They will be more or less the same between these two different types of peoples. If we just ask ourselves, why do SGLT2 inhibitors reduce heart failure hospitalizations? Is it a differential volume regulations hypothesis? It could be yes. So if we just see, if we are using these drugs like dapagliflozin, so the curve is just change between the waters inside and the plasma or even interstitial fluids is going smooth like that. Just because keep in mind the curve is like that. If you use the diuretics, which you are going to use it in heart failure patients, you will see how much the curve is going very rapid downwards, is like that, which is not giving a smooth controlling of patients with heart failures. So let us just see it in these models. If we just see the heart failure patients is like that. This is interstitial edema, edematous fat, vasodilatations of the vessels is like that. If we just use SGLT2 inhibitors, so see how the smooth change in the vasculature of the vessels. So the sodium, it will just decrease slightly, the interstitial volume, it will decrease more, and the intravascular volume, it will not decrease so much. So just compare the two pictures. If we just see what are the diuretics doing, this is the second pictures. This is the diuresis, how they do. They increase the intravascular volume so much and interstitial volume, then the sodium, it will be lost more and more. So this is the two differences between using SGLT2 inhibitors and the other type of diuretics. By different mechanisms, because of time, I will leave it. Again, if we see what they are doing inside the myocardium, if you just see here the calcium channels effect by SGLT2 inhibitors, so they will inhibit the hypertrophic gene, the cardiac hypertrophy, the cardiac apoptosis. Again, by natriuresis, it may help in depolarizations or affect arrhythmia. The end things of these bad factors, it will lead to cardiac dysfunctions and heart failures. So if we just inhibit this cascade, it will get a good benefit to the cardiovascular system. So what's about the energetic and ketones effect of such drugs? So till now, we think that it is a magic drug it's doing. So the energetic effect, if you see this is the heart failure patients with diabetes, just a little bit ATP is there. When they give one of these gliflozine drugs, like empagliflozine, the energy it will become more, and the contractions of the heart, it will become more. So this increased increase the energy productions relative to untreated diabetic heart patients. So it will give you good energy for such patients. Even in the vascular structures, so it will be benefit from vasodilatation's effect, except يمكن لو سمعتم الدكتور محمود تبع غادة وجمال ومحمود وما عندوش غيرهم كل سنة. they said that they have a good vascular except canagliflozine, which is not used in such situations because it is increase the imputation's effects. So what about the cardiac remodeling effect? They found that these drugs, they have an effect in left ventricular mass and improve diastolic dysfunctions. So there are many studies, guys, if you compare before giving the drugs and when they give the drugs, the cardiac mass, it will be reduced and it will get a good benefit of patients with heart failures. If you refer in the heart trials, again, these trials, it will lead to that these drugs, it will affect the structures, functions, and the biomarkers in a people, especially that with type 2 diabetes and the coronary artery disease. So this is just compare how they will reduce the left ventricle functions and they will get a benefit. So again, in the blood pressure reductions, they will find these drugs, they have a good effect in the blood pressure reductions. It's not that so much to kids hypotensions like in matter gas reductions. This is just a slide to see how much the left ventricular mass it will decrease. This is different studies, guys. You will see what are the effect of such drugs if they are going to use the cardiac MRI to study such patients. So the end benefits of these drugs get to reduce the cardiac myocyte effect, inhibit apoptosis, and reduce the volumes and reduce the mass of the heart. This is just a study is done, and I'm trying to go rapidly. In rats, they reduce the cardiac muscles. Again, all the fibrotic and inflammatory process, it will reduce by such drugs. All the biomarkers which you know for the cardiac, even the cardiac troponin, the proBNP, it will decrease by these drugs. One of the nice things of these drugs is productions of erythropoietins. It will just affect the renal functions by different mechanisms, lead to increased erythropoietins, which have a good effect of the cardiac patients, gas anemias. لو شفنا the CNS effect affecting the heart failures, so these drugs just inhibit renal stress. It will lead to the reductions of activations of central nervous system, وبالتالي it will affect in the heart failure. This is just a simple picture to see what's going on. This is the left ventricle hypertrophied heart here. The cytokinins inflammations increase, the extracellular matrix, it will increase, impaired systolic or diastolic functions and metabolism, then the tissues, it will increase. This is just how is the remodeling effect if the patient is giving SL2 inhibitors. What the guideline said? In brief, the guideline said, now these patients, this type of drugs, considered to be the class 1 indications in patients with heart failures. Whatever it will be the type of heart failures, either reduced ejection fractions, or MREF, mid-range or mildly reduced ejection fractions, considered to be one of the pillars of the heart failure, or even in the heart failures with preserved ejection fractions. So they keep it one of the pillars in use in the heart failures. Whatever you still start the regime of treatment of heart failure in different ways or propose a new sequentials or conventional sequentials ways. At the end, if you are going to use such drugs, you should get to know what's the indications, contraindications, cautions, initiations, and what other things. I'm just finishing. So just, okay, 10 minutes, I'll finish. So just think of all of these things and how to use them. So collectively, what can say to you in 1 minute, so these drugs except multiple effects in systemic and renal hemodynamics and cardiac metabolism, which may be beneficial in heart failure, which is sure it is a beneficial of heart failures. In type 2 diabetes treatment, demonstrate cardiac reversal and remodeling of the heart is occur within 6 months of treatment. The mechanism benefits appear to be independent of lowering blood sugars or A1C lowering, and primarily experimental studies observe either it is in diabetics or non-diabetic patient, they will get benefit of such drugs. Thank you.
شكرا جزيلا دكتور نور أخذت وقت شوية زيادة لكن عادي. الآن the next speaker the next speaker دكتور صلاح الشوكي. Where is دكتور صلاح؟ here. دكتور صلاح الشوكي.
اللي بعد أنا أتشرف أقدم دكتورة من خريجة من طلابنا استشارية أمراض الباطنة والقلب، مع أنه لا تزعلوش مني أنا عليها تحفظ على حكاية باطنة وقلب. إيش معنى القلب يا دكتور عبد الحميد؟ تذكر الباطنة مع القلب، إيش معنى القلب يضم الباطنة؟ ليش ما أقول الباطنة والصدر؟ الباطنة والكبد، يعني هذا اعتراف ضمني أن القلب السبر الدرج، هذا مبدئيا 100%. طيب على العموم الدكتورة بشرى من الكوادر الصاعدة الواعدة. هي نشاطها الكل معروف. بشرى مني تفضلي. بس يا بشرى الوقت سنحاسبك بالثانية، مش حنجاملك.